Okay, thanks very much for inviting me today. It's great to be with you here today and to share our early findings from a research project that I've been running, involved with. And also we're going to include Guy, who's been doing the local evaluation of one of the Aging Better programmes that we've just been hearing about. And I've also got some slides. Unfortunately, Louise Thompson couldn't make it today. But I've got some slides from another local evaluation project. I'm Neil Chadborn. I'm a public health researcher, and I've been doing this project called Supporting Older People's Resilience through Assessment of Needs and Outcomes. This is funded by National Institute of Health Research, and we're based in Nottingham. My boss is Professor John Gladman, a geriatrician. And just to start off with, I'm coming from a public health perspective, and just recently I think it's really interesting to note that loneliness has been shown to have quite substantial effects on mortality, and it's linked to or been seen to have as much an effect as smoking, for example, or obesity. So it's really interesting how newspaper articles have kind of highlighted this in a kind of way to draw attention to the issue. Unlike other public health issues, it is quite different from other public health issues. For example, infectious diseases, there's no vector, there's no insect to blame the issue on. Similarly, it's very different from smoking or obesity. There's no tobacco company to blame for the issue. So it is, and you can't really focus on the individual. So individualistic interventions are unlikely to be the whole answer, because it is a social issue, and it relates to our social affairs and our communities. So in terms of who should act and what they should do to address loneliness, it's clear that it's not the government, it's not a single institute. It's got to be distributed throughout our society, and especially involving our communities. And in particular, I'm going to be talking today about the third sector. That's charitable organisations, social enterprises, community organisations, and what role that they play kind of in mediating between the governmental agencies, NHS, social care, and the communities themselves. Hopefully this will work. So just to give you an overview, I'm going to be talking about 3 different projects, so hopefully you'll stay with me. Just an introduction to the diversity of services in the community. And this was from the Soprano project, the research project that I've been doing. Also discussion of the different perspectives of the local commissioners and third sector providers, and I'll give you a couple of case stories to give that a bit of colour. Perspectives on evidence and some of the tensions between again different agencies. And that the case study I'll use is from the Leicester Aging Better programme. And then Guy's going to say a few words about the approach that they've been using for their local evaluation. Now, I can't get this to work. Someone's taken it out. That explains it. So to start with, all research should have public and patient involvement, and we've been involving these groups in our research. East Midlands Later Life Forum is a kind of umbrella organisation for all the pensioners' action groups in the East Midlands. So they've been very helpful in helping us shape our research. It's still not working. I'm just going to have to press the button. So our starting assumptions, and really we've touched on this already today. Loneliness and social isolation are really interlinked with all these other issues of health and social care, Our perspective is to take a broad, comprehensive or holistic perspective on this. Mental, physical health, social care, housing, finance and community connections, and really understand the individual's perspective on this. And this is really about person-centred care in the community. Third sector organisations can provide support, but of course there needs to be sustainable funding, and again we've touched on this, and multi-agency coordination to enable all these different agencies in the community to really help the individual to deliver that person-centred care. So we started our research study, the Soprano study, with a survey of all the commissioners in the East Midlands. And I'm just going to show you this slide, really showing the diversity of different services in these communities, and different programmes, and social prescribing, for example, is a topical one at the moment that you may have heard of. But a whole range of well-being services, we might call them, or we might call them health promotion. There are all different types with slightly different aims and different programmes. So it's interesting really to consider whether these do have commonalities between them, and what different kind of mechanisms might be at work. Maybe they're after different outcomes. So the key challenges that I'd like to address in this talk. How do we reach vulnerable people? And again, this has come up as a key issue today. How do we assess their individual needs in order that we can deliver services to meet those needs? How do we signpost to services? If you've got a multi-agency response, how do you make sure the individual gets the right services? And finally, but very importantly, for commissioning and funding, how do we justify further investment? How do we put a value on this work? And some of this work is, we might say, infrastructure work. Up until recently, the CVSs in all the different towns and cities have played quite a major role, and they've recently had severe cutbacks. So without that kind of infrastructure, can these activities still be sustained? So the bulk of the Soprano research project that I'm telling you about has been qualitative interviews with these different groups of people. We've looked at 5 sites across the East Midlands, and we've interviewed the commissioner, the funder, the manager of third sector organisations, the key worker who's working with older people themselves, and we've held some focus groups with older people. So what we're trying to do is work out their different perspectives on some of these programmes, and see if we can make some recommendations about how they work together in a better way, and communicate about the communication relationships between these groups of people. So I'm just going to show you some brief outlines, really, of the interactions. So here are the different groups: commissioner, third sector manager, third sector key workers. I haven't quite added the older people focus groups on yet because I'm still in the middle of analysis. So these are just early findings, really. And I've tried to simplify in some senses what might be going on here, and what I've tried to do is think about services interactions that relate to health and care services, and interactions that are more outward facing into the community. So again, it's been mentioned today. We might have an individual who uses health and care services quite a lot but is still lonely. So how are those people's needs met? We might have individuals who have very little contact with health and social care services. So I'll come on to that in a minute. But so these are from from these interviews with different people and what they're saying. So, and I've tried to break it down into, here we've got about access to services, here we've got assessment of needs, how people are signposted to various services in the community, and finally how outcomes are reported. So some interesting things come up. So it's about continuity from the NHS, so a kind of signposting or referral from the NHS to third sector. On the other hand, for a key worker here, they're saying it's difficult to get GPs to refer. So, you know, where does the onus lie? Is it the GP's responsibility, or have third sector got to do more work in engaging GPs, for example? So these are the kind of relationships that we're trying to understand. So one third sector organisation only took referrals from professionals, from health and social care professionals. Other organisations take referrals from the community. In terms of assessment, different services need different assessments, what one commissioner said. So there's the alternative is that there could be a single assessment to cover all different domains of health and social care. And also some comments about referring back into statutory services. So maybe it's a role of the third sector, again as been discussed today, to understand people's needs and to enable people to access health and social care services. So coming on to whether organisations should be more outward facing the community, make things open to self-referral, so enabling people from the community to refer themselves to organisations. But on the other hand, a manager here is saying self-referral runs the risk of not getting a full clinical picture. So they feel that, you know, with a referral from a professional, that at least you have a professional assessment to go by first, to give you a kind of idea of what basic clinical health needs that individual has, and then the third sector can work with them to add further benefit. On the other hand, there's a concern that there may not be enough capacity if they were very public facing and just welcoming everyone. So there's all these sort of different tensions. And again, I'm not just talking about loneliness interventions, but, you know, as we discussed earlier, you know, we're talking about all the different types of community interventions, but they could all help support or address loneliness, I think. So again, in terms of assessment, we've got ideas of care planning, other aspects, quality of life, and also housing. You know, again, housing's been mentioned today, but it often falls outside of the health and social care envelope or bubble. Again, building rapport was important for this key worker. So again, not just a fairly clinical, to use a common term, assessment, but much more building relationship first. Okay, I'm going to skip some of this and go on to some of the case stories. And I just want to give these examples really to just highlight some of the stories that are coming out. Again, these are from the interviews, mainly from key workers, but what's interesting is commissioners come up with these individual stories as well. And I think that's really important. So I'm just going to read so you don't have to read, I'm just going to read some of these quotes. So this key worker had someone referred from a big call centre, and people can self-refer into the call centre, and they also have referrals from GPs, fire service, police, so they get a whole mix of people. Sometimes what we get is what they call social and recreational, but quite often those people can have complex needs. So one example was a lady, and the key worker asked, "Are you looking for groups?" And she said, "Well, actually, I've got really complex health needs. What I need is someone to come out and do an assessment of my home." So it actually turned out that the call centre had poorly understood her needs. So they had a big discussion about getting social care out and what she actually needed. And so basically the third sector organisation has worked with this person to understand the needs in more detail, and in the end got back to a social care assessment, possibly after the third sector had helped define what the issue was, and be able to express that more clearly to the social worker. So that's an example of the first kind of issue where this person has been in touch with services, statutory services, and has kind of been referred from services and with unresolved issues, unmet needs. So the other example, this is still not working, and again a huge amount of text here, but just let me read some issues. This is the other example, and we mentioned bereavement. This is about bereavement as well. This person had quite complex needs, really slow befriending to start with. Slowly but surely needs were identified. And the person might like a little bit of light dusting, is what they say, a bit of help around the house. They don't admit to them being lonely, they're depressed because they've got a health issue and they're not getting out, so they say it's due to mobility. And actually a lot have suffered quite a loss. They've lost their partner, so they're in a real low place, and they're in a real dark place. And they've not identified, due to the dark place they're in, the financial mess they're in. So they're all becoming apparent that it's the one-to-one trust that's the important issue here with the key worker and the individual, to understand this complexity and these layers, hidden layers, as was said earlier. And the key worker goes on to say, possibly it's the males in particular. It could be a pride thing. It could be that they're overwhelmed with issues and they can't quite work out what to address first. So I asked about hand-holding, and they said, yeah, it's quite important to have someone to hold their hand and to help them to access services or support, because they don't have that confidence to start with, and they might just feel overwhelmed. They may have spent a lifetime with the partner and be at a loss with bereavement, so that they need some counselling, and also the financial issues then start to become apparent or become addressed. So this is a person who presumably has had very little contact with health and social care, and yet through this work is uncovering needs, and some of those needs may be for health and social care services. So again, it's down to that question. This isn't about cost saving for the NHS. This is going to, if these needs are realised, and the person reflects and understands their needs in more detail, then they will presumably need more services, counselling, for example. So I'm just going to move on slightly now to talk about different perspectives on evidence and these kind of assessments, are different ways of collecting evidence about people's needs. And what I've been talking about is different perspective of commissioner and provider. So from the commissioner perspective, in the end it's about accountability of finances. So commissioners or funders are investing money in services, so they need data to show that what they're doing is worthy, is worthwhile. On the other hand, the local providers, it's much more about community development and local ownership of the, say, evaluations or assessments. So they're coming from quite different perspectives, and so there are naturally some tensions there. This generates a different approach to evidence, whereas the commissioner is after validated data and systematic data, i.e. quantitative data. Provider is more likely to be likely to use locally developed or locally tailored data, evidence assessments. And obviously Commissioner will be after generalisable data, as Corinna was saying, data that you can compare one population with a comparator population to try and see what difference your programme has made. On the other hand, providers, well, it's got to be time efficient, user friendly and suited to local context. So they're coming at it from different perspectives, and just to reiterate this, I've put evidence, it might be assessments or evaluation in the middle here, and these different agencies have different perspectives on this. So people investing money need to justify resources. There's also an element of research now, and all government programs have to be providing evidence. So there's a kind of research element to most public sector investment now. So there needs to be a comparator population. You've also got to be concerned about research ethics and make sure that if you're doing work that generates research evidence, it needs to be done in an ethical way. On the other hand, community partners are likely to be more concerned about feeding back to their community groups. And in some ways this is, I like to think of this bit of a football in the middle here. The assessments or the evaluations are a bit like a football being kicked around by these different agencies. So even though we might have one bit of paper that's UCLA or something like that, it's actually being used by the different agencies for different purposes, and that creates some tensions. And this is I produced this slide in the summer, and Leicester City was very topical at the time. So this a group from Leicester Ageing Together in King Power Stadium. So this issue became apparent in the Leicester programme, in particular due to ethnic diversity of the programme. And they're working with a range of languages and various literacy levels. The tools, some of the tools have translated versions, and yet we still have to question or be concerned about cultural equivalence and the construct validity. So issues like loneliness in different cultures can mean quite different things. And just the term ethnicity, funnily enough, in Gujarati turns out to be a page-long definition. Even the culture of form-filling, maybe for us white British people, we're fairly used to form-filling. Different cultures may have different attitudes, and certainly things like Likert scales, when you rate 1 to 5 or on a sliding scale, these might be quite not easily recognised or misunderstood concepts. It might just make the person just, I can't be bothered. Also, there's different cultures, obviously more of a family-based culture or more individual culture. These also affect our perceptions of loneliness, our expectations. So here's a couple of quotes from interviews with key workers again on some of this issue. The loneliness measure, when translated, didn't feel like they even made sense or were understood particularly well by the service user. So again, you've got this kind of discrepancy. If the beneficiary doesn't really understand what the questions mean, then the outcomes aren't going to be valid. An Asian person with their family, they couldn't say that they were isolated or lonely because it's a slur on their family. So you may have that sense of stigma, and that may lead to a loss of validity. But this is also about, as I said, these are very sensitive topics, and it may lead to loss of confidence for beneficiaries. Evaluation approach has to support the need of the beneficiary's confidence and trust. So if you knock on the door and start asking a questionnaire, that's probably not going to be the best way to do it. And from the quotes earlier, needs to be building that rapport, and as Kelly was saying, the need to build rapport and trust. But maybe these are some skills and that are required that maybe not all community volunteers have those skills. They may have other skills and more of a conversational attitude. They could achieve the same aim, but not with questionnaires maybe. And finally, buy-in of project staff, and certainly if Leicester has a partnership programme. So you've got several different organisations all wanting to do different things. So encouraging them all to use the same evaluation materials can be quite a challenge when their focus is on delivery again. So these different tensions play out. So I think hopefully, just to finish the Leicester bit off then, as Corinna was saying, we've got the local evaluation providing some qualitative in-depth stories here, and also we've got this test and learn approach. So we've got regular evaluation meetings in Leicester, sharing what's working and addressing what isn't working. And address the evidence needs of the local partners and future commissioners as well that they're thinking about. So again, that touches on my work that I've been talking with the CCG and the local authority, and sharing my findings back to this partnership to help them think about how they can talk to commissioners for the legacy of the programme, really. So now Guy's going to say a few words about the Lincolnshire project, the Talk, Eat and Drink project in East Lindsey.
Okay. Thank you very much. My name's Guy Dewsbury. I'm from East Lindsey. I'm actually from Community Links, which is based in Sleaford, so it's slightly down from there in Lincolnshire. And but we work on a project in East Lindsey called Talk, Eat and Drink, or affectionately known as TED, and it's part of the Ageing Better programme. And what I've come to talk about today is the Social Insight tool, which is a qualitative tool. May as well go on the next one. Qualitative tool that we're using there. For those of you who don't know where East Lindsey is, there's a little map there, Skegness. Most people have heard of that, hopefully, and a few other places that you can see on there. Mablethorpe, I think, is just up there, just in the top right-hand corner. It's quite a large, spacious, very rural area, and it's predominantly, I think it's 20% of people are over 50 years of age in the locality. The other exciting thing is that the makeup of the place, well, we'll come on to that, I suppose, in a little bit. The makeup of the place is a bit different. Talk, Eat and Drink provides a whole range of services. We do befriending services. We provide... Oops, something gone on, that's exciting. Maybe timed that one, don't know why. Befriending services. We do provide meals. We actually have social events that people go to on a weekly basis and so forth. Oh, you all right? That's that one. Yeah, give it a thank you. Yeah. Shouldn't be on any of them. Timing. But anyway, okay. Quickly flicking through all of them. The issue that we're dealing with, obviously, we hold pop-up cafes, we hold events on a 3-monthly period. We also have a commissioning arm. We have volunteer sectors as well, befriending services. All of it is about trying to reduce isolation and also uncover isolation within the area. And as I said, there's a commissioning arm as well within the where we're actually supporting local projects. One of the things that's been coming out from the CMF, the Common Measurement Framework that Corinna was talking about earlier, is we're actually finding out who the population are. And one of the things that's coming across is that they're English. And I've doubly underlined that and put that in bold. And that is because on the CMF it says, are you English, Welsh, Northern Irish and so forth, Scottish, Northern Irish. And almost everyone is coming up and they're underlining English, they're circling it, they're putting things out. Others are just crossing the whole lot out and putting in big capital letters English. So there's obviously quite a big spirit over there that people want to be identified as English, and that is it. They also appear to be Christian, and they also predominantly appear to be heterosexual. So far we've had no one identifying themselves as being other than heterosexual, but a lot of people have refused to answer that question. So it's fair enough. The CMF is being given to a whole range of people at the moment. There's a short CMF and a long CMF that we're putting out, and we're gathering data from all of those at the moment. CMF provides us with things, as we explained, it's got a whole range of different measures in there, but what's happening at times is it's missing, or appears to be missing, some of the elements that we're picking up in other ways through the qualitative data. And one of the reasons for that is we found some of the people who are lonely are also a bit dispossessed. They may have health issues or mental health issues, but also they don't actually want to complete the questionnaires. They take one look at it and they see things like, I feel a sense of emptiness and loneliness and so forth, and they immediately get put off by that and they don't want to do it, because effectively it's reflecting back to them the loneliness and isolation that they have in their lives already, and maybe they don't want to look at that time. So we've developed the SIT tool, which was an adaptation of Bill Gaver's work on cultural probes, which he did back in '99, and then I adapted it in about 2001, 2002, originally working with older people. And the cultural probes are basically, I shall quickly show you what they look like. This is the probes pack we're using at the moment, so it's all fairly simple stuff. Basically, there is a document here which is a document that has a range of tasks for them to do over a 2-week period. There's a drawing pad there, various crayons and various other artifacts for them to use in that period of time. And over the 2-week period, we're asking them to do a range of things, such as a diary, scrapbook, chart who they meet, who they don't meet, what they hope to do, what their hopes are in that period of time, what their wishes are, what they tell us basically whatever they want us to know. And the point is, it's directed by them. If they don't want to write anything, they don't want to complete anything, they don't want to draw anything, that's fine. It's not affecting anyone else. It's just what they want to tell us. Journey logs and visitor books. And in that way, we're getting quite a detailed program, an idea of who they're seeing, who they're not seeing, and what's actually happening. That's followed afterwards, after I've gone and read through all the stuff, by an hour-long or so interview, which is a fairly in-depth interview. It's a very loose-leafed interview, and it's based on basically their driving. They lead that interview. I have a guide of a few things that I want to try and bring up in it, and I will try and steer the conversation towards some of those issues in it. But by and large, it's a self-directed. They get to talk about whatever they want for that hour. We also do TED sessions and evaluation sessions within TED events, which are quite fun, where we'd get a group of people like yourselves and we'd ask you a range of questions about what they think, what it's like being over 50, what the issues are for them, and what they think the possible solutions are. And what's quite useful for that is it actually is more than, the conversation is the main part. What we're trying to do is get them to talk amongst themselves to raise the issues, as opposed to we dictate to them anything. And they come back with us and tell us exactly what the problems or the issues are. By and large, in all of those, we get really good discussions. And we've actually found a lot of evidence of the things that really do concern people. And between the two methods, what we've got is a micro method and a macro method. The SIT tool is very micro. It looks at the individual and what they're doing on that day. And then, of course, with the actual evaluation workshops that we do in the things, we're looking at the macro level. And we're slowly gathering evidence that exists about the isolation and the loneliness of the people that we're getting there. But more excitingly, we're finding out the strategies that people are getting. So some people would never see themselves as lonely, because if they are ever lonely, what they do is they open their door, they go out and they start engaging with people. These people are happy, they talk, and they're able to engage with other people, and that's the way they avoid being lonely. Or if they do feel lonely, they'll do something about it. On the other side of that, we find different sorts of strategies where people are more isolated or even have enforced their own isolation. And this is where the difficulty comes in, where we actually are finding out that people have, through choice of their own, they don't want to be with people. They've actually decided that. And that often, as much as anything, could be due to things like when the hearing goes. I know for myself, as a person who wears hearing aids, when your hearing goes, it is more difficult to engage in things. You do feel more isolated. You do feel like you want to withdraw. You don't want to participate as much. And when people have hearing, eyesight or medical conditions and things like that, they are tending to withdraw, and they're able to recount that to us through these probes quite nicely. By and large, what we're trying to do is marry, as was said in the first speaker today, the quantitative and qualitative together to try and actually get a rich picture of what's actually happening to the older people, people at least over 50 in East Lindsey. And I think we're beginning to get there. It's quite exciting. It's quite an exciting time at the moment because the evidence is beginning to come in and it's beginning to start giving us something that we can actually deal with. And I think the two are complementing each other really nicely. And we're beginning to start finding out, putting icing on the cake of the CMF, I think, at the moment. There you go. I'll hand over.
Thanks, Guy. I was just going to say a few words in summary, if I've got time. So what we're seeing is different approaches to evaluation and assessment. And I think this is important because how assessments are delivered, how services are delivered, shape how loneliness is experienced. So as we've said, the assessment process or the evaluation might make that person reflect back on their situation, their loneliness. Might make them realise that, oh, I'm more loneliness than I thought. I don't know. But this sense of expectation, social expectation and perception is very important. So I think it is very important how we do these assessments and evaluations, and different ones might be suitable for different people. And what I've tried to sort of cover in both of our talks, possibly we can come up with two sort of caricatures, if you like, or vignettes, as they're popularly called, of a kind of complex case, an individual who is in touch with, who does go to a GP, maybe goes to A&E from time to time, has complex issues that kind of need untangling, and loneliness is in the mix there. Hopefully, if those issues can be resolved, then they may have less need for health services. So that's a quick win for the NHS. The other case is the hidden issues, the bereavement, as we've mentioned about. These people might not be in touch with services. They need a sensitive and need to build rapport with the key worker in order to unpick and uncover issues that were previously hidden. So this is going to bring about more needs, unmet needs. So this isn't going to be the quick win, but hopefully it will avoid crisis later down the road. Also, as we've touched upon, we need to be aware of ethnicity, sexual orientation, gender, and this has got to be in the mix as well. So our assessments and evaluation approach has got to be sensitive to these issues and cultural issues. And what I'm trying to describe is that third sector can play a negotiating role, but to create a negotiated order between the public sector, health and social care, and the community services and community support that's available, and enable people to move between the two and provide that support. So thanks very much for listening.